Hi everybody, thank you for coming, and I'm really proud to be sharing our COVID Hangover report, which is published today. So as Alison said, I'm Sadie Boniface, Head of Research at the Institute of Alcohol Studies in London and Visiting Researcher at King's College London. And this presentation is a double act with Joshua Carr-Gowers from Health Lumen. So first you have me presenting the introduction, and then Josh is going to present the methods and results, and then it'll come back to me for the conclusions. And this project is a collaboration between IAS and Health Lumen and was funded by NIHR's Policy Research Programme. So I think many of you listening will already be aware that changes in alcohol consumption in the UK have been one of the indirect effects of the pandemic. And we go through this in a lot more detail in the report, but there have been a lot of surveys during COVID, especially during the first lockdown, that found between a fifth and a third of adults were drinking more than before the pandemic. At the same time, a similar proportion were also drinking less. So like I said, a lot of these were done in the really early stages of the pandemic, but then taking a little bit of a longer view, overall, there hasn't been a huge amount of change at the population level in terms of alcohol consumption or alcohol sales. However, and it's a big however, there have been clear and sustained increases in the prevalence of increasing and higher risk drinking, as shown on this graph here. And there's also other evidence that heavier drinkers began drinking more during the pandemic. So this graph is from England's Alcohol Toolkit study. It's one of the only surveys that has continued throughout the pandemic, and you'll hear a bit more about it this morning. So this graph goes from 2014 up to February 2022. And the purple shading is the periods of lockdown, but the pandemic is kind of, you can see that with the big virus molecule on the graph. So before the pandemic, we had a little more than 25% of people were increasing or higher risk drinkers in England. But you can see very clearly this has increased with the onset of the pandemic, and it's been sustained since. So this graph from our report just goes up to February this year, but the latest data goes up to June, which came out last Friday. And if you look at that, it looks exactly the same. It hasn't changed. Things are not starting to go back to normal yet. In Colin's presentation a little later, he's going to talk a bit more, I think, about how the changes in alcohol consumption have been concentrated among heavier drinkers. So I'll move on and talk a little bit about what's happened with alcohol harm. So I think a lot of you might be aware from headlines that there was a 20% increase in alcohol-specific deaths in England and Wales in 2020, and that took this measure, alcohol-specific deaths, to the worst levels on record. Again, like the changes in consumption, this has also been sustained since. So this graph is going from January to December and shows the trend in alcohol-specific deaths in the most recent years. So there's an increase in alcohol-specific deaths, which has been sustained from May 2020 onwards. Now, initially, that was in the first lockdown at a really emergency kind of time. You could have attributed that just to changes in access to healthcare and other services. However, this increase has been sustained, just like the changes in consumption. And this graph also goes up to February 2022. It's a little bit difficult to see, but it is still above the 2018-19 levels. In our report, we have a similar graph showing an increase in liver disease emergency admissions, and these have also been above pre-pandemic levels since June 2020. So both the alcohol-specific deaths figures and the emergency liver disease admissions show the biggest increases among people living in the most deprived areas. So increases in alcohol harm, which we know were already bad, are also widening already. In terms of what motivated us to do this project, there's been a lot of other work which has made this work possible. So at IAS, we have monitored the changes in alcohol consumption and harm since the start of the pandemic, and we wrote 2 briefings. It feels like ages ago now. The first one was in June 2020, and then the second one was in October 2020. Since then, there's been several peer-reviewed publications we've drawn on for this research as well. And we've relied a lot on PHE and OHID resources too. So there was a big report from Public Health England, which came out last summer. And there's also the wider impacts of COVID-19 tool that's looked after by OHID. In our first briefing, we could see that changes in access to healthcare caused by the pandemic together with the changes in drinking that were being identified in the surveys, might mean that alcohol harm gets worse, but that this is less visible to healthcare and other public services. So while we're now past the acute emergency phase of the pandemic, we know the NHS and other public services have not recovered, and IAS and others have been warning that we could be storing up problems for the future. At the same time, there's also been a lot of uncertainty about what will happen with future alcohol consumption, and that's where the motivation to model the longer term health impacts has come from. So in October 2020, IAS and Health Lumen jointly led a bid to NIHR's policy research programme to model the longer term health impacts of these changes in alcohol consumption, and the project was awarded funding in spring 2021. So that's it from me on the background. Now I'm going to hand over to Josh, who's going to present the methods and the results. So over to you, Josh.
Thank you, Sadie. So I'll just briefly introduce Health Lumen for those who might not know us. So we're a microsimulation company that was born out of the UK Health Forum around 3 or 4 years ago. And we use a microsimulation that's well validated in the literature to model the future of risk factor patterns, non-communicable diseases, and their costs. And then we also apply scenarios to determine the impact of particular interventions on these non-communicable diseases. So this microsimulation model is simplified in this graph here. So first of all, we generate the population. So in this case, we've used data from the ONS and socioeconomic status data from the census. And then each individual is assigned a risk factor value, so a alcohol consumption estimate. And that was derived from data from the alcohol toolkit study. We're modeling 6 cancers here, and hypertension, stroke, and liver cirrhosis. And each individual will have a particular risk of having one of those diseases based on their alcohol consumption value and their age. In addition to that, we also model health economics. So each person in the model has a cost associated with their condition. And then, as Sadie mentioned, there's uncertainty about how long these trends in increased alcohol consumption will last. So we modeled 3 scenarios. The first one being the most optimistic, so the short-term scenario where everyone will revert to pre-pandemic levels in 2022, and then the medium term where everyone reverts in 2024, and the longer term where there's a permanent increase in alcohol consumption. We also model cancer care of the 6 cancers, so things like tumorectomy, how many people are on radiotherapy, and so on. So once we've generated this representative virtual population of the UK, we then feed them into the microsimulation model, and that advances annually from 2020 to 2035. And each year we update each individual's disease status, record any mortality and morbidity associated with that. We update the year in the model, and we advance each person's age and their risk and their alcohol consumption value. That cycle then continues until 2035, until the end of the simulation. And as outputs, we record the incidence of disease, premature mortality, which are deaths under the age of 75, direct healthcare costs to the NHS, and healthcare utilisation as well. And we compare our baseline results, which assume that the pandemic never happened and 2019 drinking trends continue, against one or all of these 3 scenarios with different lengths of impact of COVID on alcohol consumption. So our first set of results presented here are the excess cumulative incidence of all of the diseases that we're modelling. So under the short-term scenario, which is the most optimistic, we're projecting around 3,000 additional cases of disease in 2022 alone. And that increases all the way up to 150,000 additional cases of disease between 2022 and 2035 if alcohol consumption doesn't revert to the levels that it was in 2019. So this breaks down those figures into the excess incidence of each of the diseases that we're modelling. So under the medium-term scenario, which is looking much more likely than the short-term scenario at the moment, we're projecting around 25,000 excess cases of hypertension, 4,000 cases of stroke, 2,000 cases of liver cirrhosis, and over 4,000 excess cases of the cancers that we're modelling. And those cancers are liver cancer, mouth cancer, esophageal cancer, throat, colorectal, and breast cancer. And you can see those broken down on the right-hand side there. And then the impact of as the duration of this increase in alcohol consumption continues over the long-term scenario, assuming that they never revert back to 2019, we have a much more significant impact of alcohol consumption. So around 100,000 cases of hypertension, 20,000 cases of stroke, and 20,000 cases of the cancers that we're modelling. And interestingly, the incidence of 7 of these 9 diseases that we're modelling increase more relative to baseline in the lower socioeconomic group under all 3 of these scenarios. So under the short-term scenario that we're modelling, we estimated there would be £360 million in excess direct healthcare costs, going all the way up to over £1 billion in the long-term scenario if drinking never reverts. And on the next slide, we have a breakdown of these costs. So although hypertension, as we talked about in the slide before, has by far the greatest excess incidence, the most costly diseases that we're modelling are stroke and breast cancer. So we include an example here for the medium-term scenario, where drinking patterns in COVID-19 continue until 2024 before reverting. So stroke, we project an excess cost of around £250 million, followed by breast cancer, which has an excess cost of around £96 million, and then hypertension is around £73 million. And the other diseases that we're modelling, so liver cirrhosis and the other cancers, they're projected to have an excess cost of over £150 million between 2022 and 2035. And finally, we looked at the impact of all of these diseases on excess premature mortality. So these are defined as deaths that occur under the age of 75. And in all 3 scenarios, this impact is felt the most in the more disadvantaged group. So under the short-term scenario, for example, we project that the number of premature deaths is around 200% greater in the more disadvantaged group, for example. And the difference in the number of premature deaths in both groups, the difference between those in socioeconomic groups, narrows a bit over time, but there are more excess premature deaths in the lower socioeconomic group under all 3 scenarios.
Thanks so much, Josh. So there's a lot more results in our report and even more in the final report to the funder NIHR as well. So that's just a whistle-stop tour. The main message of the study is that these increases in additional cases of disease, extra premature deaths and extra NHS costs are not inevitable. So the diseases that we've modelled are all chronic diseases, and this health harm takes years to develop. So it is possible to prevent these extra cases of disease, these extra deaths and extra NHS costs. As well as that, our results are really not the full picture. So we've only modelled 9 diseases, and there are 200 or more related to alcohol. Although we wanted to as well, we were not able to capture anything about harms to others. So we haven't looked at things like the effect of drinking during COVID on children and families, on things like drink driving, domestic violence, and we've also not looked at quality of life or mental health. Colin's work, which you'll see shortly, does include a wider range of health outcomes and a bit of a longer time frame, but again, it's still not a complete picture. Now, we also have the cost of living crisis as well, and that might bring further impacts on alcohol consumption and harm. So increased alcohol harm is one of the indirect effects of the pandemic, and we've already seen these increases with the alcohol-specific death data that I showed at the beginning, and our model projects longer-term chronic disease impacts too. And we think these indirect effects should not be neglected in COVID-19 recovery planning. Kind of this time last year, there was a lot of emphasis on building back better, and there continues to be government priorities around levelling up. And tackling indirect effects of COVID, like alcohol harm and the inequalities it entrenches, contributes to both of these government agendas. So in terms of what we recommend and what we think should be done, we know there's already an evidence base. Lots of you listening will already know there's an evidence base for population level policies to reduce the harm from alcohol. And our recommendations will be quite familiar to a lot of you. So we have 5 main recommendations as part of a new alcohol strategy. So I'll go through those in turn. So the first one is to increase funding and resources for alcohol treatment and support. And that's over and above what has been promised in the drug strategy that came out last December and should be based on anticipated need. Alongside that, there needs to be more resources for primary and secondary prevention, such as screening and brief interventions. Number 2 is to capitalise on the opportunities that are presented by the new alcohol duty system that's set to come in next year. So the principle that's been put forward of a strength-based system is very welcome, but the duty rates need to be consistent across different categories, and they should automatically increase in line with inflation as well, which is all the more important now that inflation is at a high level. Number 3 is to introduce minimum unit pricing for alcohol in England, so aligning England's policy with Scotland and Wales. Regarding the minimum price level, others have recommended that Scotland uprates their minimum unit price to 65p per unit from the current level, which is 50p. Number 4 is to add protecting and improving public health as a 5th objective of the licensing system in England, again, as it is in Scotland. This would enable health more broadly to be part of local decision-making on alcohol's availability. And then finally, number 5 is to improve the regulatory approach to alcohol marketing to reduce exposure and influence among the vulnerable. Now, this is a really big recommendation. In terms of specifics, we point to Alcohol Focus Scotland's new framework for alcohol marketing regulation, which was developed by their expert network and came out 3 or 4 weeks ago, I think. So in the report, we present the evidence behind each one of these recommendations. We also talk about public support, which is really quite high in a lot of cases. And we talk about the relevance in the current context. So thinking about how hospitality has been hit by the pandemic. So these measures do not have to hurt pubs and restaurants. And we also write about them in terms of the cost of living crisis that we now face. So what's coming out from our project? We have the IAS report, the COVID Hangover, which is out today. We can put the link to that in the chat box. That's about 30 pages long. It's very accessible. It's got pictures in it. But if you haven't got time to read a 30-page report, we have a 2-page briefing, which is also out today. And that tells you everything that you need to know and has the main results in it. If you want a lot more detail, there's the NIHR final report. So that's to our funder, and that's more than 50 pages plus lots of appendices. And there you will find the detailed results for the cases and costs broken down by each disease, and then also by socio-demographics, so by deprivation and by gender and a lot more. And then there will also be a journal article, but that is not out yet. So lots of things coming out from our project. So just to end, Josh and I presenting today, but there's a whole research team behind this project. So thank you to all of them, as well as all the other people listed here who have advised us along the way. And thank you to you all for listening. Thanks very much.
It now gives me great pleasure to introduce Colin Angus, who is a Senior Research Fellow in the Sheffield Alcohol Research Group at University of Sheffield School of Health and Related Research. Colin's work focuses on the design, development and adaptation of complex health economic models and their use to appraise key policy questions in the field of alcohol research. So this has included modelling the potential impact of alcohol taxation and minimum unit pricing policies on alcohol consumption and harms, modelling the relationship between drinking patterns and health outcomes, and understanding the equity implications of alternative policy options. And Colin's been at the University of Sheffield since June 2011. So this morning, Colin is going to present the methods and findings of his research, looking at the impact of changes in alcohol consumption during the COVID pandemic on future health harms. So over to you, Colin. Thank you.
Super. Right, I'm going to start by saying that, like, some of you might think that this is some amazing, super coordinated thing to have published these 2 reports at the same time, but actually it's like a crazy coincidence that we both independently were doing the same thing using quite similar approaches at the same time. And when we found out, we decided that it made sense to try and launch these things at the same time, since we've basically done the same thing and the messages are reassuringly consistent. So just in case you think that we're very, very clever, we're not. It's just life is strange, I guess. So, okay, so this is the very catchy title of our report. You can tell that we're a bunch of pointy-headed academics. And I just want to start by acknowledging my very helpful co-authors, Maddie and Rob. And normally at this stage of a presentation, what I would do is I would go, ha ha ha, look at me and our funny academics with our stupid long titles. Here's a pithy title that summarizes it, but I'm afraid the IAS folk already beat us to the good title, so I'm not even going to try and do that. And instead, I'm going to signal that we're going to play a little bit of spot the difference here between our work and the work that Sadie's just talked about. So I'll try and focus on the things that are different and the things that are kind of complementary, rather than just presenting what we've done in isolation. So we've got, you can see who employs the graphic designers here and who's the boring academics. Right, so before I do any of that, I just want to acknowledge that NHS England, NHS Improvement funded this work, and they're lovely, thanks, folks. So yeah, just to, obviously the pandemic had a huge impact on our lives, and in particular, the lockdowns and the various restrictions changed the availability of alcohol and the context in which we drank it. So where we were drinking, when, with whom, and such things. And obviously there were lots of other stresses and potential triggers for harmful drinking. But if you look at HMRC clearance data on the total amount of alcohol sold in the UK, so this is a graph showing you the historic range between 2015 and 2019, and then 2020 data, you can see an initial dip in March during the first, when the first lockdown started, and then we overcompensated in the summer. And overall, alcohol clearances increased very slightly, 1.8%, but not a huge amount compared to the previous average. And if you look at 2021 figures, it's a slightly bigger increase, 5.5%. But it's not like a crazy spike in alcohol sales. And yet, as Sadie's already shown you, if you look at the prevalence of risky drinking, then there is this really obvious step change. So, academically, I'm very curious about trying to work out what's going on. Just because, well, Sadie said Colin's going to show you lots more details about this, so I hastily piled in some extra graphs here to show you some of the details behind this. So this is equivalent data from the toolkit separated by sex. So you can see that both men and women saw this jump up in the prevalence of risky drinking. In absolute terms, the increase in men was bigger, but in relative terms, it was bigger in women because the prevalence was much lower to start with. If we look by age, you can see that all age groups saw a bump up. The biggest relative increase was in younger adults, actually 25 to 34-year-olds, but 45 to 54-year-olds had the highest prevalence of risky drinking to start with. You can see that we see the same increase across all socioeconomic groups, although not necessarily to the same extent. And then if we look at different drinker groups, so this is kind of the proportion of people who would fall into each one of these different categories based on their score on audit. So actually we saw a fall in the proportion of people saying that they didn't drink at all. Not much change in lower risk drinkers, a jump up in risky drinkers, hazardous drinkers, harmful drinkers, and a non-significant increase in people who would be categorized as probable alcohol dependents, or having probable alcohol dependence. And so we've seen this kind of shift in terms of what groups people are in, but you can also use this to calculate how much they're drinking on average. And if we do that, then we see something slightly interesting. If you look at the lower risk drinkers, you can see there's a bit of a downward trend going on there, whereas there's not much of a trend in the other groups, maybe a slight upward trend in the probable dependence group, but that's a small sample and much noisier. So we've seen more people drinking at risky levels, but potentially the people drinking at lower risk levels are drinking less. So, how do we square all of this together? So that's kind of what our study was trying to do. So quantify how drinking changed in 2020 to 2021, make some sensible assumptions about how that might change in the future, model it all. And the way that we did this is by analyzing data from the alcohol toolkit study, which is this, a similarity between the two studies, but I'm going to bring it as a difference because we did we analyzed it in a slightly different way. although it was the same data. So there's our first spot the difference. We also made some assumptions about how drinking will change in the future. And we did this by consulting with various stakeholders at OHID and the NHS England. Again, we came up with some slightly different scenarios, although reassuringly, they're kind of, they're some similarities between them. So we know that they're not, totally wild, I guess. And then we modeled the long-term implications of those changes. And this is kind of the biggest difference, right? So we used a different model. We have the Sheffield Alcohol Policy Model, or SAPM. We did use 2019 as the baseline year, and our kind of counterfactual is as if the pandemic never happened and everything carried on in sort of 2019 style. So there you go, there's the big difference. And kind of the key methodological differences, as we've already heard a little bit, rather than looking at 9 health conditions, we look at 45. I know Sadie said 200, but it kind of depends how you group them together. So we think that's a pretty comprehensive overview of the health conditions for which there is robust evidence. There are a bunch of other conditions, things like prostate cancer, for which the evidence is a little more equivocal, that we don't include. But as Sadie again said, we're only looking at the harms drinkers experience as a result of their own drinking. So we're excluding harm to others, including medical issues like FASD, but also things like violence, drink driving, domestic violence, things like that. There are a whole load of subtle methodological differences that I'm almost certain none of you care about, but feel free to drop me an email if any of you are weirdly interested in that kind of geekery. For example, our model isn't really a micro simulation. It's what I'd call a quasi micro simulation, but these are the kind of things that only sad people like me care about. And we use a longer 20-year time horizon to account for the full lagged impact. So the evidence says, the epidemiological evidence says, if your drinking changes now, your risks of harm don't fully change for up to 20 years for some health conditions. So that's the rationale there. Okay, so what did we find? Well, we found that there were different effects for lower risk drinkers to risky drinkers in terms of the effects on their drinking. So we found that the lower risk drinkers reduced their consumption, bigger reductions in men, younger people, and the highest socioeconomic group. But the risky drinkers, the people who are already drinking at levels potentially harmful to their health, increased their drinking. And the patterns are kind of interestingly mirrored, right? So although it was the male lower risk drinkers who cut down the most, it was the male risky drinkers that increased the most. Similarly, the male high socioeconomic groups that reduced their drinking the most, and the same groups, but the risky drinkers increased their drinking the most. So there's this real polarization going on. And then our 3 main scenarios, we modeled 5 in the report if you're super interested, but the 3 ones were this sort of immediate rebound. That's kind of a best case. Everything in 2022 goes back to 2019 levels. Our main scenario, we said the moderate drinkers go back in 2022 to their 2019 levels, but the risky drinkers, they maintain their risky drinking for 5 years and then gradually over the next 5 years go back to 2019 levels. And then the worst case scenario, this increase in consumption, is that we say that as the pandemic kind of fades into the background, hopefully, the people who were drinking a lot in pubs beforehand, they keep their new elevated levels of home drinking and also add back in some of the pub drinking that they've sort of missed out on over the last couple of years. And what does that mean for health? Well, it's bad, right? So what we find is that in our main scenario, a 1.7% increase in hospital admissions over 20 years, alcohol attributable hospital admissions over 20 years, and a 5.7% increase in deaths. Even in that best case scenario, 0.3% and 1.5%. And in the worst case, the numbers are much bigger. But this is all percentages. What does this mean in terms of actual numbers that you can get your head around? Well, over 200,000 hospital admissions and over 7,000 additional deaths in our kind of main scenario. Even in the best case, it's nearly 43,000 admissions and 1,800 deaths. And in the worst case, the numbers are pretty scary, nearly 1 million hospital admissions and over 25,000 deaths. So these are, even if in your most optimistic worldview, these are pretty unhappy numbers. And the cost of the NHS, which, doesn't need any of this, at the moment, given all the other pressures that are going on, Our main scenario costs an additional cost of over £1.1 billion, and rising to over 5 billion in the worst case. And even in the best case, it's £200 million. And in terms of inequality impacts, we sort of reassuringly find similar things to the IAS report. So we find the biggest, because although the biggest increases in consumption among risky drinkers were among the higher socioeconomic groups, the harm is so much higher in the lower socioeconomic groups that kind of gearing flips back the other way. And we see the biggest increases in harm in the most deprived groups. Okay, and in terms of numbers, we'd expect 693 additional hospital admissions per 100,000 drinkers in the least deprived group, and it's nearly double that in the most deprived group. Okay, so that's widening absolute inequalities. Although it is worth saying, if you're more of a relative person, the baseline difference is so big that actually in relative terms, that increase is biggest in the least deprived groups. So we estimate absolute inequalities will increase, relative inequalities will reduce slightly, but only because things are getting worse faster for the least deprived group. So that's a kind of a bit of a Pyrrhic victory, I guess, if that's the thing that you're interested in. So overall, drinking is polarized. Even in the best case scenario, 42,000 additional hospital admissions and 1,800 deaths. And if we make more pessimistic assumptions, which, to be honest, seem more realistic, given the fact that there's very little evidence that the initial lockdown shock from back in April 2020 has dissipated in terms of levels of risky drinking, these numbers could get much bigger. And of course, we're already seeing this happening. And it's interesting that although all of this analysis is just focusing on England, things aren't just getting worse in England. It's just that we've shone a light on what's going on in England here. So if we look at alcohol-specific deaths across the 4 nations of the UK and the USA, because the USA happened to also publish data on this, which is nice of them, you can see over there in that grey shaded area, that's 2020, you can see they jump up in all of these countries. So we've already seen worrying things happen. And this is just potentially the start of the harms that we've modeled in these reports. And obviously the healthcare services could really do without this at the moment. So maybe we should do something. Sadie's already talked about what that something might be. I'm an academic, so I'm not going to tell you what to do. I'm just going to go ooh a bit. Anyway, that's enough from me. Thank you.
There are 2 questions, so I'm actually going to merge them into one rather than invite you to ask them, take chair's prerogative, because they cover the same sort of issue. So Sarah Galvani and also Hussein from NACOA have asked what the rationale was for choosing to explore disease and NHS costs as opposed to including at least social costs. Hussein gives the example of costs to children of dependent drinkers or wider familial societal harm. So I'll start with Sadie, but also then Colin, if you want to consider an answer as well. Sort of we're at the start, I suppose. So the rationale, but then also any future plans.
Yeah, so to both people asking a question, yeah, I agree. It would be really nice to have included those either within this study and done something more comprehensive, or to do a future study. It's a really neglected area. We were not able to do that because of the availability of data. I don't know if Health Lumen have anything more specific to say on that, but basically the kind of data that's needed on consumption and relationships with alcohol consumption and harm doesn't really exist for some of the social harms and harms to others. Does anybody want to expand on that? Because that's not quite my area, or we can move on to Colin. John?
Yeah, I completely agree. Thanks. Yeah. And it would be a fascinating topic for a future study, absolutely.
Yeah, I'm just going to boringly agree with that. Basically, there's 2 reasons why we didn't do that, as much as I would have dearly loved to look at that. And one is the fact that the budget for this study wasn't sufficient to cover developing a whole new model, although that's something that we'd like to do, addressing building a model that can look at wider impacts beyond the immediate health on the drinker, and also have a greater focus on people at the sort of dependent end of the spectrum and the impacts of policies on those. They're kind of like are great white whales, right? They're the things that I've been looking to do and desperately wanting to try and do for a long time, but that's really hard because the data on those things is not what we would like it to be. So I'll carry on chasing that particular whale, but I'm not promising I'm going to catch it anytime soon.
Actually, one of my questions has been answered in terms of the proportion of the IASHL study, what proportion of total harms you tried to capture, but I think we've seen that with the Sheffield one. So it's useful to compare the two, a snapshot versus an attempt to capture the whole lot. My other questions are slightly geeky perhaps, but maybe important. It seems to me, as a non-mathematician, I would have thought that if you have a difference between groups that's maintained, then that difference will just get greater and greater with time. But it seemed like in the HL model, for example, the effect on the most deprived groups, the lower occupational groups, got less with time, in terms of the short, medium versus long-term scenario. And I wonder if you could explain why that is.
Yeah, so I believe that was for premature mortality. So it's not necessarily a case that the impacts on the worst deprived get better over time. It's the fact that there's more premature deaths that are expected in the higher socioeconomic group, and hence that difference narrows. So it's not that there's less of an impact on the lower socioeconomic group over time. If that makes sense. And if you look in the full report, some of the results for the short and medium term scenario are quite interesting, because the cumulative incidence, of course, starts to decrease because people are dying earlier and they're not getting a particular disease. So that's an important point to consider there.
Which I suppose is the point that both your study and the Sheffield study suggests that the big increase in mortality last year wasn't just that these people were only going to die once, as people do die once, and that's going to suddenly disappear. You're arguing that problem is going to continue. And I think these are great studies in terms of headlines which will grab the attention of policymakers.
Like when we compare with the big increase that we've already seen, right? So my strong suspicion, although we don't have the robust evidence to confirm this, is that there are two major factors underlying the big jump in alcohol-specific deaths that we've seen. And one is the changes in drinking that we're talking about here, but the other will be everything that happened with specialist alcohol treatment services during the first months of the pandemic, when there's a whole bunch of very marginalized dependent drinkers who were just no longer able to access those services because they all moved online and they don't have online access or whatever. And so and none of that is captured in either of these models. Feel free to correct me, but I'm, they're certainly not captured in our model. So if anything, that makes the modeling work we're talking about here conservative with respect to what we've actually seen, which is scary, I think. But I think that's important to kind of acknowledge.
One other question, which is slightly in the geeky mode, which is probably answered in the 50-page version, but we're all kind of talking about the polarization to sort of use shorthand as the reason for the increased harm in the face of no huge increase in overall consumption. And I'm interested that will be different according to which disease you're looking at. For example, in my own field of liver disease, there's a kind of threshold beyond which you start to get a big increase in deaths. But for some diseases like breast cancer, it's a more linear dose response curve. So do you see different responses according to the disease you're looking at? For example, in breast cancer, did you find an increase in overall incidence, or was the increase in the heavy drinkers counteracted by the reduction in the moderate drinkers?
Yeah, you're right. All of the details in this long report, and I can't remember all the 50 pages, but we do take into account different relative risks for each kind of alcohol consumption band. And in some cases, such as liver disease, you'll see a sharper rise in the risk of getting a disease and then subsequently dying from that. So that is taken into account in the model as well. And of course, some diseases don't have such good granularity of relative risks, but others do. So we try and extract the best data that we possibly can and then use that in the model. So Colin, I don't know if you want to touch on what you did with your model?
Yes, I mean it's exactly the same, but I think that kind of maybe the way to respond to this is to say that if you look at the various studies that have tried to calculate the kind of the aggregate risk, right, the overall risk of some bad outcome, whether that's illness or death, as a function of your drinking. You know, if you look at the individual cause specific shapes of those curves, there's all sorts of mad shapes, some of which may or may not be biologically plausible, but that's a different argument for another day. But essentially, if you average all of those curves, the shape that you get is increase, it rises like that. So increases in drinking at the heavier end of the spectrum bring a bigger increase in risk than increases at the lower end of the spectrum. And that's why this polarization is particularly bad, because you're getting a reduction in the bit of the curve where a reduction doesn't mean a big change in risk, and an increase in the bit of the curve where an increase means a big increase in risk.
Fantastic, thanks.
Great, thank you. Mari, you had a question about cost of living, which I think is really important to have a bit of a discussion about here. I know Sadie referenced it in her presentation. So I don't know, do you want to come off mute and pose the question yourself to our panel?
Yes, thank you, Alison. I had another question a little later on about something slightly different, but I just thought with the looming and even imminent cost of living crisis, which is going to get a lot worse in the autumn when the energy caps go up a lot, whether there'll be a reduction in disposable income, and therefore people will be forced to cut down, maybe less so in people that are addicted to alcohol, but there'll just be less money to spend on treats like alcohol and going out to pubs and restaurants and so on. So I just wonder if that's going to have an impact on like consumption trends, possibly. Be one to watch, I guess.
Thank you. And I guess Sadie, and then I'll ask Colin for his views. Do we have any indications yet of which direction this will go in?
It's tricky. So it's a bit like with the pandemic, we didn't really know. There wasn't a lot of previous evidence. There's a systematic review now about alcohol during past pandemics, but there wasn't kind of when this all kicked off. There's a bit more evidence about what happens to alcohol consumption in like economic crises and recessions. I don't know if the cost of living crisis is really the same thing as that, but what that evidence kind of suggests is that there's not going to be a big change in overall alcohol consumption, but a bit similarly to what we've seen with COVID, there might be more polarization and like a greater increase in inequalities in alcohol harm as well. So that's kind of what happened after like 2008-9. So I think it's not looking good. The cost of living crisis definitely not looking like a solution to the problems that we're outlining today. If anything, it's going to get worse. How much worse is very difficult to say.
I think that there is a prediction we are going to go into recession. We'll have to wait and see. But I also read something recently, I can't remember the source, that said there'd actually been a 15% drop in consumption of alcohol generally by the overall population in recent, compared to maybe 10 years ago. As I say, I'm a bit vague about where I've read that, but I don't know if you know about current, about overall.
Yeah, no, it's important to think of it in relation to longer term trends as well, because there was life before 2020 as well, and there's been longer term shifts. For example, younger people drinking less. That's been happening for at least sort of 15-20 years, I would say, in the UK, and that's a pattern in other countries as well. But at the same time, there's also increases in older people's drinking that carries more of a risk of longer term health harm as well. So it's really difficult to put it all together, and these studies really are focused just on the effects of COVID, and we're not looking at those other underlying longer term trends or the cost of living crisis. But I would say overall the outlook's not good. But does anyone else want to add or correct me?
I mean, I think I'd just add to that the clear, we don't know what's going to happen, like you say, and the clear lesson from all of this work that we're talking about today is that just looking at the population average can hide that tells far from the full story. You need to understand how different groups are being differently affected, and there might be good reasons to think that a recession would reduce the relative affordability of alcohol, so maybe people will buy less, but it's also going to make a lot of the other factors that interact with alcohol and health to produce harm worse. So there's things pulling in all sorts of different directions, and it's a braver person than me that's going to start sticking money on what we're going to see at this stage.
Hi.
So,
Hello, everyone. And sorry, I have 5 minutes because I have another meeting, so I'll be very quick. It is in terms of, well, we've seen, and there is data from the US, at least on the changes in alcohol availability, increased in sales due to home deliveries and online sales, and they are now being consolidated into law in many states and not reversing back. So my question was if the model is or could model that on top of just the consumption, but making a darker future, actually, when you account for the weakening of policies, because I assume these are in the three scenarios with the same policies in place. Thank you.
I think that's a great question, and I suppose if I, in a sort of final thought from Sadie and Colin and Josh, where would you hedge your bets in terms of what we might see the future unfolding, given the cost of living, changes in alcohol policy, and just what we're seeing in terms of alcohol trends? So, Sadie, do you want to answer Maristella's specifically, and then I'll invite you both to sort of hedge your bets.
Okay, thanks, Alison, and thanks, Maristella, for your question. So we've used what actually happened to alcohol consumption during the pandemic. So that would be taking into account the kind of more restrictive aspects of alcohol policy, like or pubs being completely closed for several months, but it would also take into account where things have been relaxed. So the first example of that that's come to mind, it's probably not the best example, but is like increases in pavement kind of drinking and dining when things reopen to try and keep people outside in the fresh air. So we have used what actually did happen to alcohol consumption. So we're using kind of everything mixed up together. We haven't been able to kind of disentangle what had what effect on consumption, and we're not looking at the impact of that in the longer term future as well. But we have seen similar things where relaxations and tightenings of different aspects of policy are becoming permanent. I'm aware of that from other countries as well. I think other places might be a bit more of an issue than it's been in the UK, is my understanding, but yeah, definitely something to keep an eye on for the future.
I've already hedged my bets. But
okay, I'll let you off.
I mean, I guess all I would say is that that something, a unique feature of the pandemic, right, is that this is fundamental, by it's forced the way that people drink and the places that people drink to be different, to change, right? It's forced drinking into the home setting. It's forced people to buy alcohol in different ways from different places. And so it's different from other kind of simpler shocks where you might just see a sudden change in price or something. There's a whole lot of kind of policy, it's like what are normally policy levers, but in this case haven't really been done by policy, that have been pulled at once. And we don't really know what happens when you let them all go and put them back, how much those things stick. As I said in a presentation, it's kind of surprising to me and a bit worrying that we haven't seen like an initial jump in risky drinking that then fades off, which is what I would have guessed beforehand. It's kind of continued, which suggests that maybe some of those new behaviors are sticking, but how long or to what extent and how all of that interacts with the cost of living crisis and whatever policy or not any future government might want to introduce is, for braver people than me to guess about.
Thanks, Colin. I'm really sorry that we've run out of time. Thank you so much to everybody who's posted comments and questions in the chat, for being so engaged in this topic this morning. And thank you, Sadie, Josh and Colin, for really excellent presentations and for fielding all of those questions. And thank you everybody for attending. And yeah, this is the start of crystal ball gazing, I think, and seeing what will unfold in the next few years. But let's hope that it also leads to some real policy change that will help make sure that these predictions don't come true. So thank you, everybody, and enjoy the rest of your days.